Similar to the rest of the roundtables and panels, we want to start by highlighting success stories, and then we want to understand the challenges that we're facing as we address these issues, and more importantly, collaboration opportunities so that the people in this room, and maybe people aren't in this room, but those that are going to hear about this later will have opportunities to tackle these issues together. And so I think a good way to start, and let's start on that end, if everybody could give a 1 or a 2 minute introduction, since we are short on time, who you are, what you're working on, why you're here, and then we'll go into a guided discussion from there. Thank you.
Hi, so I am Kelly Pompilio. I am the Alexandria Police Department social worker, the PSW, and I was hired last year in July, and about August, I think Chief presented to me the heroin epidemic that we'd had. We had several overdoses in the community. It was occurring on a weekly basis. We were responding to the same calls, along with fire, to administer Narcan. And so we came up with, we looked at several different models that other police agencies are using and developed our model based off of that. We use the Alexandria ACTS Angel program, so Addiction Community Training and Support. We have monthly community meetings where we educate the community on the heroin epidemic. And then we have angel volunteers who, myself and an angel, will respond to every overdose or any suspected individual who is using any type of substances. And we assist.
Is something never heard. 64,000 deaths a day on one cause in a year, never heard. So it's a challenge for everybody. So the president has appointed a presidential commission, and they came up with the interim report, which they expect to release final report sometime this week or next week. And hopefully they formulate some specific guidelines how to deal with it from different angles. That's said, prevention and interception and treatment, and recovery and rehabilitation. All these things were addressed and to be addressed. And simultaneously, the boss who's paying for all this thing is CMS, the Department of Medicare and Medicaid Services. They were obviously more concerned than anybody else, and they came up with a white paper in the beginning of this year, and they laid out complete a roadmap from A to Z of what we should do it. So I think that's what's in Cincinnati needs, not the dance floors. And they're looking to clean up all the streets from this opioid deaths, horrendous as they are, and it has happened to be a reality for them. And that's the first line of smart cities that should be addressing it. So that's where we are, and I have a number of guidelines that I can relate to you afterwards as we go along. And we have complete plan from that point of view and the technology that we could use to address the overall picture in a comprehensive way.
Thank you. Can we give our panelists a round of applause just for their dedication to addressing this issue? And for those that don't notice, I'm going to moderate this panel from the front row, so please bear with me. So I have a couple of specific questions, but before we dive into those, I wanted to open up a question to the group. What do you think the single largest challenge is in addressing this epidemic?
Well, I got one mic, so I'll start.
That's fair.
All right. Probably the biggest issue is stigma. We still look, and I'll go off of what the doctor said, I hope within my career we change addiction from a crime and put it into the mental and medical health system that it should be. So hopefully, I got maybe probably 10 years or left. Hopefully within that time, we change this. We're not going to get all these initiatives, all these programs to get it shifted over there if we don't change the stigma. We have to stop looking at it as a crime. They're not criminals, and we have to take it out of the justice system. I'm a cop. I'm good at investigating crimes. I put handcuffs on people. My job is not to be that addiction specialist. I shouldn't be out there necessarily trying to intervene on that level. If we can change the stigma, I think we'll make a difference. That's probably the first thing.
So you made a good point that you're not an addiction specialist. Kelly, do you want to speak to you being hired in Alexandria and that different approach that law enforcement is taking in your district in addressing this issue?
Sure. So the heroin is just one little small piece of the puzzle that I do at the police department. What had happened was the chief of police in Alexandria had looked at all the different call responses that the department was doing, and I think it was like over 70% of calls that the department.
Different treatment intensities, lengths may work for different people at different times. We also subscribe to, the use of medication-assisted treatment, so use of buprenorphine, methadone, and incorporating that within the treatment, but helping patients get to our clinic, helping families know what their treatment options are, helping patients get to our clinic, and then helping patients stay in treatment, because ultimately, addiction is a chronic disease. So it probably, for most people, requires lifelong management. And so we're really trying to think about how can we get folks either from the community, or if they present at our emergency room, how can they get from our emergency room, let's say, to our clinic and get the treatment that they need, and how can we also support their families? Because addiction doesn't just usually affect one person. It affects kids, it affects parents, and so how can we treat the whole system that's affected by addiction?
Interesting. So what you're describing is almost a ripple effect that is realized when the...
Yeah, potentially. Oftentimes our patients present with their significant others, their parents, their kids, and so certainly we want to treat the addiction in the identified patient, but it's also supporting the whole system. They oftentimes need lots of social services. This is a complex problem that doesn't. It needs lots of resources, and it needs lots of interesting and novel ways to address the epidemic from all angles.
So you bring up resources, and Tom, this reminds me directly of the lunch that we had last week. It seems to me that there are plenty of government resources to go into programs that are really aimed at benefiting the community. I asked this question to the group: why is it so difficult to identify funding sources to support these programs? Where are those challenges, and what can we do to break through that barrier? One thing that I've recognized that is happening, especially in this region, is aggregating data to better identify what these trends are. And that gets us to the point that we can start creating trackable, measurable outcomes so that we can track our progress or our lack of progress. And as we do that, do you think it will be easier to obtain the resources, the funding, the support, and the community building around addressing these issues?
Now, I want to put in the right perspective the problem itself. I don't want to go to the end point and treat the symptom and say we cured it. That's not the problem. That's not the issue here at all. So it's the overall understanding of the issue, problem itself is an important thing. Starting right from the provider, the physicians and the nurses, assistants, whoever was treating all these pain problems all these years, we never thought of it as going to be a problem for us to ever to respond to this kind of a serious situation. So now it's recognized that the first you start educating the physician, the providers, nurses, everybody else, that pain management is not a simple thing to deal with it. There are consequences if you just overdo it. And so the first thing the CMS recommended was you register all the providers, which is 2.3 million providers in the country. They alerted them, you better register it with the Department of Drug Justice Department, and then start monitoring them. So then you were saying that, well, when we come to the possible, situation where they may be getting addicted, then we'll focus on them. That's not what it is. 75 to 80% of these patients, approximately, let's say about 2 million are addicted to opioids to overdose now. 75 to 80% of them went like you and your neighbor and myself, when you got back pain or neck pain or something else, car accident, went to the hospital or doctor, and they gave a simple pain medication treatment. And that led on to the addictions over a period of time. 75, 80% of them, it wasn't them. They weren't looking for it. They are not the criminals. They are not the drug addicts. It's a past history. This current situation has nothing to do with it. It was started in the medical profession. It started with medical professionals, and they were unaware of it, what was going on here. So that's how we ended up here. Now, of course, reverse the situation back. What the CMS wants to do is, first of all, like somebody mentioned already, alternate medications. Find out what is the best way to treat this pain injury, or back pain, neck pain, whatever it is. You set the guidelines, the best practices, how many days you need this medication if you need pain medication, and how to monitor it. So essentially, you end up saying, monitor all the providers, monitor all the pharmacies who are filling. How come this guy's selling 100 prescriptions a day? Next door neighbor only selling 5 prescriptions a day. So they want to monitor the providers, monitor the pharmacists, monitor almost every beneficiary who is asking for the pain medication. They're innocent as anybody else. So they don't know what they're getting into it. So somebody has to keep track of them and make sure these people understand, yes, you're entitled for the medication to get rid of the pain, but you have to be watchful about it. You should beware of the problem that you may end up with it. So it's a serious thing. It's a massive problem, massive data we needed, and technology appropriately should be set for that so that all these providers, all the stakeholders could be engaged and make that is a common problem. It's not somebody else's crime. And so that the whole culture has to be changed. It's not the question of stigma. Everybody is ignorant. It's not the victim that is stigmatized. The whole profession is stigmatized. I don't ever, being a medical person, be accused of this kind of situation. And they were responsible for it, and they weren't told about it. I mean, they're part of it, they were responsible. So this is a serious thing. Everyone should be part of this thing.
Yeah, Zach, I was going to say, there's actually two parts to this. So as a law enforcement, I sit across from a coalition, and I work with doctors, hospitals, treatment, harm reduction, prevention. And everyone says, well, we need this, we need this, we need this. I look at this as two ways, because we're responding to 50 to 70 overdoses every single week. We're responding to 4 to 5 people that die every week. So for us, this is an emergency. So there's two parts of this. This is long-term, that prevention, the medical aspect of it. How do we prescribe medication better? How do we get people into treatment easily? How do we transition from law enforcement into these social connections? But there's another part of this. The people who are overdosing are not the kids that we're talking to in the grade school. Our average overdose victim is 27 to about 45 years old. So we need to figure out a way, number one, to stagnate that. Because everyone looks at me on the coalition, like doctors and treatment, they're like, Tom, you're not putting 50 to 70 people in my hospital. You're not putting 50 to 70 people a week in my treatment center because we don't have the capacity. We can't do that. And I look back at them and I go, I'm a cop. All I can do is Narcan somebody and try to get them help. That's it. My success rate is almost zero. I can keep you alive, but I'm not keeping you alive. I'm only keeping you alive long enough that you use again, basically, until I can connect you somewhere else.
Can you elaborate on that a little bit?
Yeah. So we use 7,500 kits of Narcan within 1.5 years. The city of Cincinnati and Hamilton County responded to 8,000 overdoses. A year ago, we had 200 overdoses in 1 week, and I stood in front of the media and asked the governor, we need to declare a state of emergency. We're bleeding. We need a tourniquet. Since then, 5,000 overdose calls in that 1 year. 430 people died in that year. Number one, we need to look at this as an emergency. Declare it an emergency, treat it like an emergency, stagnate it so that hospitals, doctors, prevention, treatment, all these programs that we were working on can work. The reason why they're not working right now is because we're in emergency mode. Once we stop that, then the other things will connect. So I look at it as two issues. Number one, the emergency, and number two, long-term care. How can we continue that long-term care so we don't repeat what we've done in the past?
Do you have any thoughts on that, Ashel?
No, I mean, I totally agree. I think, whoops.
No one noticed that.
I think one of the things that we really are focusing on is we did the shock and the wow. We already know the data. We know we see 5,000 plus overdoses in our ED system this past year at St. Elizabeth in Northern Kentucky. So, and what they're seeing in Hamilton County, we already know where we're at. And I agree with you. Now the part is, where do we need to move next? You know, so one of our docs said it best, and so we just got some federal dollars, and I'm sure you saw the recent article if you haven't, that it's actually funneled through the state of Kentucky, but we are through the CARE grant, and we are going to try to get those people, when they arrive to our emergency rooms, connected right to a peer support and then right to a treatment. And we do get about 5+% of patients who come in through our emergency room who want treatment. I can find treatment for them. I can get them a detox bed. I can get them to the next level of care. It's how do we keep them there? What we were missing and we realized is we don't, and like you said, it's so complex. That continuity of care is very difficult for us to manage. So once you leave one agency, then where did they go next? And so we're losing them in our community, and really what they need is care coordinators. They need case managers. These individuals need case managers to be able to manage that continuum of care, just like we do our other diseases. These insurance companies don't want people to be readmitted within 30 days. They get case managers. They get a person to call them and say, how are you doing with your meds? Are you taking your medications? You know, how are you doing with this? we don't do that for addiction. We need to look at this a lot differently, and I think that we'll be in a different place. But one of our doctors said, you know, Ashel, who we need to focus on is not the 5% who knock down our door looking for treatment. We need to focus on the 95% who don't know that it's available and that we can help them. And that's really what we're shifting our gears to. We really want to touch every single person, and we're doing that as ER nurses and social workers, but it comes different when you're talking about a peer person, speaking to them, that they've lived it, they've been there, and they're on that road to recovery. It will hopefully make an impact, and we'll hopefully make some big moves in that. But then again, then it comes down to what's next, and then we have to keep them in with a case manager and that continuity of care.
So as we look at what's next, and I hate that I have to rush towards this, but because of our lack of time, I would like to go down the row and try to understand how can people in this audience or members in the community collaborate with each of you to help us get to creating these better outcomes. Kelly, you have...
Can I start that?
Oh, okay, let's start down there.
Well, let's connect to we talked about this is our smart cities we're talking about today. Where does smart city belong in this opioid problem? Not the dance floor and like in Barcelona. Our problem is keeping our street clean, keeping our city clean from the opioid deaths every single day, which is horrendous for the people who are dealing with on an everyday basis. So that means we talked about monitoring them, keeping track of them, get ahead of them. So that means connectivity is the most important thing. We don't have a record. We don't know. We give the prescription, they go away, and we have no follow-up on them until we see a sudden in the emergency room. So the first step in that direction is, of course, we all think we have electronic medical record when they go to the emergency room or the hospital. They're not. And they are not obviously secure, and they have been hacked repeatedly. And we need the stakeholder, the patient themselves, be part of this record. And they have to start day one when they get the first prescription for cocaine or whatever, opioid prescription. That has to be tagged and record maintained to have continuity of care. So those things, wherever they go, that one of the things they're promoting, they're asking as CMS, is to have the consumer themselves be in charge of their personal health record. It's their record. They should be the boss here. They should control the record. So they want, number one, consumer immediate exchange requires everyone can have their own record. Wherever they go, this state, next state, wherever, they all could be tagged. Next, number two, that with the prescription from here, it goes across the state. The pharmacist cannot prescribe unless he checks his record. Who gave the prescription last time? How many medication, how many pills were given, what dose was given, what strength was given, was 6 milligrams or 10 milligrams. Every little thing here has to be tagged. And that's what they're heading for it. So this smart city, the number one relation to the healthcare is they must have that connectivity, that you have 5G and the broadband things. They don't need internet at home. We have smartphones. We can connect all this with the data, including we have the devices. We can monitor the patients when the pulse rate down, whatever, and that could automatically be triggered to the your data center, and they could be tagged and followed up. So the technology is very critical. The smart cities has a critical role to play in this problem. So that's where we start with it.
Couldn't agree more. Should we just go down in the order, and I apologize to Russ, each of you, because you are the experts and this is a pressing issue in our region, but how can people here or at home collaborate with you as a final takeaway?
I will do my best to keep up with the conversation here. Everyone here, I've been working on this for 3 years, and I think I've taken a screenshot and marked down some of the points you've made, and Zach, it's an honor to take part in this. I'm not a physician, but I do have a history of addiction, and I do know that if I were to walk down these stairs right now, a real world situation is I slip, I hurt my back, I get 7 days worth of pills. What we are working on is the ability for me to have that ability for early intervention if I go through 7 days of pills in 5 days. Right now, 70% of the people who end up injecting heroin start out with getting the pills from friends and family. If we can remove those illicit pills and then I have to come back and see the physician, they will be able to see me coming down off these prescriptions, withdrawal symptoms, and be able to make divert me on a different path.
So how do people here collaborate with you?
Collaborating would be keep an open mind with prevention. Whenever I hear the word prevention, people sometimes maybe think of just education, teaching kids. But if there's a way to deter people from going down this path and having their brains switched on and rewired for the rest of their lives, I think that's a huge key. It's a lot more expensive to treat people than to prevent the illness.
So we've heard use technology, connectivity, and data. We've heard keep an open mind.
I'll put on my research hat for a moment. I think some of the technologies you all are probably working on have great promise. And as the researchers at UC, one of our tasks is to collaborate and not reinvent the wheel. We're not IT folk. We don't know how to design the most slick technological interventions, but we can help you test them, and we can help you gather some evidence as to whether or not the technologies you're doing can be efficacious and help our patients. So I would throw out that if you have something you're working on, I won't speak for my colleagues, but would be happy to think about collaborations both on the research side so that we can evaluate the work that you're doing, but then also how can we get the technologies that you're working on into the hands of our patients who ultimately need them. So how can we help both evaluate what you're doing and help you with that, but then also how can what you're working on be leveraged to help and address this epidemic and connect the dots. You know, this is multifaceted. Technology has great promise to help connect some of these dots in continuums of care, prevention, law enforcement.
So it requires an interdisciplinary.
It does, and lots of people, I think, sitting around the table with their individual areas of expertise coming together to try and find novel solutions.
So technology, keeping an open mind, general collaboration. Really quickly, the last 3 ways to collaborate with you 3 experts.
Yeah, Zach, you won't take me to lunch again because I'm not going to say technology. It is perception. We cannot get nothing done without the public changing its perception. You dictate policy. You dictate where governments go. You dictate where people go. If it's healthcare, if it's not healthcare, got to change the perception. Take addiction out of the criminal justice system, put it into the medical health system, and then we'll succeed. That's where you connect.
Thanks, Tom.
And I couldn't agree more. I think the stigma, support efforts in your community. I can't say that enough. Either it's syringe access, or if it is a community center that wants to come up, or a church. Churches, our faith-based community has stepped up tremendously in Northern Kentucky as well, helping with this addiction. So support efforts in your community. And again, with the technology, I have to kudos to the research at UC. We're welcome to that as well. I do a lot of data for the community. So if you need to say, okay, we want to look at this pocket of community, we worked really closely with Alexandria to say how many in our community are being affected by this, and I was able to get them some more statistics. I've been able to break it down by male, female for another treatment agency who is looking to put some things in their community. So we're here to help. I agree, I don't want to invent the wheel either, but if there's ways that I can help you get more resources in your community, and or you want us to test something, please let us know as well.
Awesome. Kelly, we'll end with you. How can people work with you?
Kind of hit on the ideas that I was thinking. I think, like she said, connecting the dots and being able to track these individuals, from entry level to what have they been able to successfully do, not successfully do, and not putting them back into, say they go to a detox facility and they relapse in a week after that. Being able to track that and understand that, so that way when I come in and work with this individual, I can see through our data collection that yes, they went to detox. 2 days later, they relapse. What happened there, and what can we do next? Should we get them straight from detox into residential treatment, inpatient? What does that look like for that individual? So being able to track and collect that information to be able to assist the individual a little bit better.
So I would say that we have a lot of work to do, and I think that this is hopefully a good start for more regional collaborations in addressing this issue. Because we do have to cut this panel short, I'd like to thank each of you unfortunately, we're out of time, but I'll make sure that we connect after. The next panel is going to be with the city of Cincinnati, and so we have to stick to them with the press schedule. So, panelists, thank you so much for joining us. I'm looking forward to continuing the conversation with each of you.